Good afternoon. For those who are punctual, thank you very much. We'll wait a couple minutes for this antiretrovirals for prevention session. Usually give people a couple minutes to assemble, so thank you. Good afternoon. You're on the call for the antiretroviral for prevention educational session. We're going to wait just one more minute as people are still joining the call.
Next.
If folks can mute if you're not speaking, that would be very much appreciated. We'll get going just in a couple seconds. There's just a few people still joining the call. Good morning, good afternoon, good evening. I'm Ken Mayer from the Harvard CFAR on behalf of my co-chair of the Antiretroviral for Prevention Working Group, Patrick Sullivan of the Emory CFAR. We're delighted to welcome you today to one of our education sessions on the use of antiretrovirals for prevention and the research thereof. Today, we're really fortunate to have two excellent speakers who are going to be focusing on HIV prevention issues for women in the US and around the world. Our first presenter is Dr. Christina Soros, who's a clinical psychologist in the behavioral medicine program at the Massachusetts General Hospital and Harvard Medical School. She's associate director of that program. She's an associate professor of psychiatry, of psychology in the Department of Psychiatry at Harvard, and a member of the qualitative research unit at Mass General. Her clinical practices focus on women's health and optimizing the health of individuals living with chronic illness. And she's director of the behavioral medicine elective of the internship in clinical psychology at Mass General. So she mentors junior investigators, postdoctoral fellows, and other mentees and students. Dr. Lynn Matthews is associate professor and director of the Global Infectious Disease Research Program in the Division of Infectious Diseases, and associate director for global health and health partnerships in the Global Health Institute, all at the UAB Hersink School of Medicine. She's trained in infectious diseases and internal medicine. She's a clinician scientist funded by the NIH to develop interventions to implement HIV prevention programs, particularly focusing in the context of reproductive goals for women and men affected by HIV. And she's worked with partners in South Africa and Uganda. More recently, she expanded her scope to focus on HIV testing, care, and prevention in Alabama. So without further ado, Christina and Lynn, please take it away. Before you start, I just want to ask people if you can please post questions in the chat, and Patrick Sullivan will be moderating discussion at the end of our session. Thank you.
Great. Thank you so much for the lovely introductions. And thank you to the CFAR for having both Dr. Matthews and myself. I know I speak for both of us and I say we're excited to be with you all today, and we're grateful to you all for joining. So Lynn and I will be sharing some existing data and also some information about ongoing projects that we have related to PrEP use for women, both in the global context, mostly sub-Saharan Africa, and also in the Deep South. Next slide, please. By way of disclosures, I've served as a consultant to Brown University and UNC Chapel Hill. Dr. Matthews has received some operational support from Gilead for some of the data that will be presented here today. As I mentioned a moment ago, we hope to just briefly outline some of the key issues when we think about PrEP use among women in the global context in terms of the need and also our success thus far getting PrEP into the hands of women who may benefit. We'll share some findings from 2 projects looking at PrEP uptake and use in Uganda and South Africa, and we'll provide an overview of some ongoing work that Dr. Matthews and I have in Alabama around increasing PrEP use. And lastly, hopefully we'll kind of start to facilitate a discussion and think about some of the similarities and differences across the different contexts and talk about kind of maybe what we see as next steps to move forward this important work. Next slide. So Dr. Matthews and I are going to kind of switch off here. So I'll turn it over to you, Lynn, so you can cover some of the background.
Yes, sorry. So it's taking me a second to find mute. I hid my controls. Great. So I think this audience knows this data pretty well. This is a meta-analysis showing that oral PrEP to prevent HIV works for women when it is taken. And really the take home is here, looking at this meta-analysis of several clinical trials that form the basis for approving PrEP, TDF FTC PrEP for women with 75% adherence, about 60% reduction in HIV acquisition risk. But the key is, of course, if it's taken. My work has really focused on thinking about how to get HIV prevention into the hands of women planning for, or people planning for and with pregnancy. We have a lot of data, including this great data generated by Carrie Thompson and Renee Heffron, showing that looking at many women in prevention studies in sub-Saharan Africa, if you look at their risk for HIV acquisition during pregnancy and postpartum compared to not pregnant states, there's an increased risk of HIV acquisition, even if you control for things like the viral load of the uninfected partner. And if you're thinking about mother-to-child transmission, which is more common among women who become acutely infected during pregnancy or while breastfeeding, UNAIDS data from 2020 in this slide adapted from Lynn Monfison shows that about a quarter of remaining PMTCT cases or mother-to-child transmission cases do occur in women who acquire HIV during pregnancy and breastfeeding. So we've spent a lot of time thinking about how to prevent mother-to-child transmission once a woman is pregnant and living with HIV, but how to prevent her from becoming infected during that pregnancy has been a little bit less of a focus and is an area where I've really focused and thought about. So strategies to minimize peri-conception HIV transmission if the male partner is living with HIV, there's a couple, but PrEP is a really important one. Male partner being on treatment and virally suppressed is another key one. For the purposes of this talk, because of the data that we have around safety and pharmacokinetics of cabotegravir in pregnancy, we're really going to focus on daily oral PrEP for women planning for and with pregnancy. So what are the benefits of using PrEP in the peri-conception and pregnancy period? We've been saying for a while that maybe this is a motivated population that may have time-limited PrEP needs. PrEP for all of sexually active years seems to be pretty hard for people to do, but maybe this could be a more focused time where adherence could be successful. It's something that the uninfected partner can control, even if the partner living with HIV doesn't necessarily test or disclose or is not able to reliably take treatment and be virally suppressed. It's a great opportunity to link uninfected people who are exposed to HIV into kind of comprehensive prevention care. But there have been real concerns about adherence, something this group I'm sure talks about a lot. So in the clinical trials context that generated the evidence base for PrEP is prevention, there was high adherence, at least in the main studies that contributed to that. But in the subsequent studies, as in demonstration and implementation projects with women, most in sub-Saharan Africa, studies with pregnant women, studies with adolescent girls and young women have had lower adherence than we would like to see in order for women to be fully protected by taking PrEP. And there's lots of different ways to measure adherence. This is refill data. This is coming back to clinic. This is MEMS adherence. This is drug levels from one of Dr. Kellum's studies. And this is also drug levels in HPATN 082. What I wanted to show was, if you think about this slide that I think you guys have all seen, it's generated by AVAC, showing that the effectiveness in clinical PrEP trials is really driven by how many people or what proportion of the study participants took PrEP. If you look at the studies that are very effective, like IPERGAY or Partners PrEP, at least 80% of participants had detectable drug levels when they looked at subsets. Now, if we go through this and think about where did these post-trial effectiveness demo implementation projects fall, and PIA is around here. So really none of the women had protective levels. The 3PSP study is here, and you can kind of go across and think about where we are. This study by Devora Joseph Davy and colleagues in Cape Town was a study of PrEP for pregnant and postpartum women. They did see a pretty good return to clinic rate at 6 months. Their drug levels are a little bit lower, but this is, one of the studies where it looks like maybe at least some of the women are taking enough to be protected. So we had this hypothesis that women, and based on a lot of formative data, that women planning for pregnancy might be motivated to get up into those higher adherence levels. So I conducted a study with Christina and others in South Africa called, I'm not going to read this because it's embarrassing if there are any Zulu speakers in the audience, but it means protecting yourself before pregnancy, and we call it the ZINC study. We recruited uninfected women planning for or with partner plans for pregnancy in the next year in Durban, South Africa, where HIV is quite highly endemic. The women all reported a stable partner living with HIV or whose serostatus was unknown. And we offered them kind of a package of safer conception care, including daily oral PrEP with adherence support using Life Steps, which Christina is going to talk about next. Our aims were to look at PrEP uptake as part of safer conception care, basically HIV prevention that allows for pregnancy, and look at objectively measured adherence to PrEP during periconception and pregnancy periods. We looked at plasma tenofovir levels. We have some dry blood spot levels, and we had MEMS cap data for daily PrEP pill cap openings. And then we had a qualitative component to get into more depth with how PrEP was working for women planning for pregnancy.
Thanks, Lynn, for setting me up just to speak very briefly about how we support adherence. So as I just take a look at the audience, many of you are already very familiar with Life Steps, but for those of you who might be less familiar, Life Steps was developed as a single session medication, HIV medication adherence intervention developed by Steve Safran in collaboration with Dr. Mayer and others. And the idea here was that there are some essential steps in which one must engage in order to be an effective consumer of any medication or treatment or prevention tool. So those steps are understanding why you're using the product and how to use the product. You'll have to get to routine medical appointments for monitoring, to visit your provider. You need to obtain your medications or your prevention. You need to know how to talk to your providers, ask them questions, manage any side effects, come up with a schedule and reminder strategies to take your medications, store the medications, etc. So Life Steps, again, originally developed for HIV treatment adherence, but we have modified it and adapted it on a number of occasions now to meet kind of the PrEP context. Next slide, please. And Life Steps varies depending on the context and the setting in which we're trying to use it to support adherence, but in general follows a cognitive behavioral therapy approach, which ultimately in this case, we help individuals understand how to solve their problems in a different way. And in this case, the problem that we're solving is taking a medication or an HIV prevention agent in a way that will promote prevention effective adherence. So we provide information information, we explore motivation, try to increase motivation when needed. And then there's a lot of collaborative problem solving around barriers to engaging in the desired adherence behavior, and in some cases, supporting other sexual health goals as well. LifeSteps is always manualized to ensure that individuals get kind of key elements of the intervention that we think are important, but it also allows for a great amount of flexibility so that it can be client-centered and also delivered by individuals with kind of varied levels of training. So we have used lay counselors in the case of much of Lynn's work in sub-Saharan Africa, in the US with Dr. Mayer and others. We've used nurses. So again, it's flexible, and session length is variable. First sessions tend to be a little bit longer because we're setting a stage to help individuals kind of engage in this adherence journey. Subsequent sessions are very variable and are as long as they kind of need to be. So if someone is doing well, they can be quite brief. If someone needs more support, they might be a little bit longer. And we've also explored a number of different training models and paradigms that generally include some didactic training, a lot of practice, and then ongoing support and supervision. Next slide, please. And then I do just want to note that LifeSteps for PrEP was recently added to the CDC compendium of evidence-based interventions to support PrEP use based on a trial led by Dr. Mayer and also Dr. Safran. So I've just provided those references there in case they're of interest. Next slide, please.
Great. So I'm going to head back to South Africa where we conducted the study where we used the LifeSteps intervention. And I'll highlight that our counselors were Bongeka Kia and Mkhulisi Matendwa. So this is a February 2020 picture back when like team study visits were more frequent and maybe more fun. Everyone looks very happy here. Jenny Smith was not in this picture. Jenny Smith is the site PI, very involved PI for this particular study. Manjita Jaggernaut was co-PI at the site with Jenny. So this is the study team, and I'll mostly just highlight that we did this work in partnership with Match Research in Durban. And many other people helped contribute to this work across CFARs and non-CFAR communities as well. So as I mentioned, we recruited, I need to make my floating controls go down here. Okay. As I mentioned, we recruited uninfected women planning for or with partner plans for a pregnancy in the next year in Durban. Median age was 24, and we actually had a very well-educated population, still very high unemployment as is typical in South Africa, but these women were recruited in and around Durban city center. And a lot of them had completed some of their university studies, and some of them had completed all of their university studies. Most had had a prior pregnancy, and most had one sexual partner in the past 3 months. And most of the women, their partner was a boyfriend or long-term partner. Are you all seeing my pointer, by the way? My pointer displaying on this screen share. Christina, you're saying something, but I can't hear.
I see it.
Okay, cool. Thank you. And not super surprising to people familiar with South Africa, but I think striking to a lot of people who see this data and don't know the South African realities. 96% of the women coming into the study did not know the serostatus of their partner. PrEP uptake for, again, this cohort of women planning to have a child was about 60%. The remaining women chose other methods to prevent HIV acquisition around pregnancy. Also, some decided not to have children based on some of our counseling or informed by some of the counseling. And if we look at 12-month adherence, what we see is that overall the median adherence is 63%. But as you have seen in many other studies of daily oral PrEP, adherence starts high and then kind of stabilizes out and then kind of drifts away. So women interested in using it, some women were able to use it well, others were not able to use it as well. And this is the electronic pill cap data. This is daily pill openings. We had pretty low pregnancy incidence, which I'm not going to get into details of in the formal talk, but it's a great question if anyone wants to ask it. But 35 women became pregnant while using PrEP. And for those women, we were able to look at their pre-pregnancy adherence and what their adherence looked like post-pregnancy. And what we saw is that it was actually pretty stable. Women took about 60% of their pills during their pregnancy time. This is a rich slide, which I'm not going to be able to give full justice to, but I will take you through this. And so this is showing the proportion of PrEP users that had different categories of adherence based on in the yellow gold pill cap data or the MEMS-cap data or plasma in the blue. The darker bars or the darker parts of the bars represent the proportion of women who had high adherence. Now, what's high, what's low, that's all very much debated, but here we called high adherence women who took greater than 80% of their pills based on the pill cap data and greater than 40 nanograms per mil of plasma tenofovir concentration. And what we see is that, at month 3, we've got between 30 and 40% have high adherence based on one of these measures. That goes down to closer to 25 to 30% at month 6. Then 9, and by the time we get to month 12, it's around 20 to 30%. And this is of women who chose to use PrEP in this cohort. I appreciate that the pill cap and tenofovir plasma levels actually match pretty well. And I'll move on. We had 11 incident infections. Not surprisingly, no one became infected during pregnancy. And among those who did not ever use PrEP, their incidence was not surprisingly higher. So some of the conclusions from this work and next steps for us during the periconception period, we've talked a lot about the periconception period being high risk, but this is kind of the first cohort data showing that it is a high risk period, particularly in Durban, South Africa. We saw high interest in and acceptability of periconception PrEP with continuation during pregnancy for the people who became pregnant. And some of the patterns around that adherence and our qualitative data, which are published, but I'm not going to talk about them right now, suggest that just like a lot of other studies, women are different and different women need different kinds of support depending on their situation. Some women, I think, will benefit from different modalities of PrEP. Others may need an entirely different approach altogether. I'm going to switch and talk about a similar study that we conducted, also using the Life Steps for adherence support in rural Uganda. So we asked again, how do women exposed to HIV around pregnancy use periconception PrEP? We recruited uninfected women in Mbarara, Uganda, with personal partner plans for pregnancy, with a partner known to be or likely to be living with HIV. Again, offered comprehensive safer conception counseling, including PrEP at the quarterly visits with Life Steps to support PrEP use. We looked at uptake of TDF-FTC PrEP over 9 months. This study was not initially funded to follow women through the pregnancy period. We ended up adding that on, so we have that for some of the women. And we looked at adherence in this study using the WISE pill device, which is another kind of electronic pill cap, basically, and tenofovir levels, plasma, and dry blood spots. And then we also had a qualitative component. Our team here, we collaborated with Mbarara University of Science and Technology, and that team is listed here. Deo Tukwatsibe was our counselor who Christina and her team trained in the Life Steps intervention. And here's our team in November 2019. Dr. Bosco Buono is the site PI for this work. Dr. Esther Adakunda led the qualitative component. And this is Deo Tukwatsibe, who is a nurse and a counselor who led the intervention components, or led the Life Steps adherence support for the clients. So in this study, we recruited 131 women. Their median age was 28. Most had a couple of children already. The vast majority had one sexual partner, and the partner they were planning to have a child with was either a spouse or someone with whom they were living as married. This study, unlike the last one I presented from Durban, 74% knew that their partner was living with HIV or reported to us that their partner was living with HIV. They had very high perceived HIV risk, and most were having condomless sex. Here, PrEP uptake was 90%. And when we followed women out over the 9 months, which was the main study period, unless they became pregnant, median adherence was, was 87%, with actually like pretty tight confidence intervals. And for these women, we had a very high pregnancy incidence, 53 pregnancies among 131 women, 75% incidence. And again, we looked at what was their adherence before that incident pregnancy and after for the women who had data on both sides of for all the women who became pregnant, and they maintained their adherence through the pregnancy period. This again is this bar chart, stacked histogram chart, showing us what the data looked like for this cohort with pill cap data, tenofovir plasma data, and dry blood spot data at 3 months, 6 months, 9 months. Now, this is, I will say that but my epidemiologist colleague, many people will freak out a little bit about this chart because it's not the exact same women in each column. We have dried blood spot data on a different group than on, there's overlap across these, but we have the dried blood spot data is more complete than our plasma level data. So take that with a grain of salt. But again, just like in the zinc or South Africa data that I showed you, the darker bars represent higher adherence. So 3 months, over 80% of women were able to open their pill cap every day and ostensibly take it. We see a pretty high level maintained across the 9-month follow-up. The drug level data are a little bit lower, but they seem to match each other at least. So if we take the highest levels of dry blood spot data and the highest levels of plasma tenofovir, between 50 and 65% of women are protected at 3 months, a little lower at 6 months, and by 9 months, it's around 45, 50%. We had 1 seroconversion in this study, also a woman who was not pregnant, and she had taken PrEP. She had not, did not have detectable levels in her tenofovir plasma or in the dry blood spots. So some of the conclusions from this work, HIV exposed women in Uganda planning for pregnancy really embraced PrEP as part of safer conception care. And by pill cap, most were able to take daily oral PrEP. Drug level data, a little harder to interpret, but even if we kind of use like the most rigorous cutoffs there, somewhere between 40 and 70% of periconception women did sustain adherence to PrEP. From this, we take that women planning for and with pregnancy should really be prioritized for PrEP implementation, particularly in settings with high fertility rates and generalized HIV epidemics. And just as a teaser, our qualitative data for this are published by Dr. Adekunda. Our quantitative data are under review somewhere. So putting these two studies side to side, they're really different data, really different findings, but also very different contexts. PrEP uptake, well, so in Uganda, we had much higher uptake and adherence, but we also had women who were a bit older, who were in married partnerships, knew their partner's status, in a rural setting where the DOH or the Ministry of Health guidelines at the time indicated PrEP for women with pregnancy. When we conducted this work in South Africa with a slightly younger population, most of whom were planning a pregnancy with a long-term partner in an urban setting where only 4% knew their partner's status, the Department of Health had also contraindicated PrEP use in pregnancy because they had concerns about safety data. That's no longer the case, but that was the case when our study was ongoing. And so if I put this back on this AVAC chart with my little stars, kind of roughly indicating where the different studies fall in terms of drug adherence, our Healthy Families PrEP study, if we use the gold star for our pill cap data, we're around here. For our plasma or our dry blood spot levels around the 9-month point, we're more like here. Our zinc data is around here. There's 2 other studies I didn't mention before, which are periconception PrEP, pretty small studies. One was done in Kenya by Renee Heffron and colleagues, and they showed in their cohort of women planning for a pregnancy, 81% had high adherence by pill cap. Ashley Leach did a study at Boston University and published it for a small study of serodiscordant couples planning for pregnancy. 87% of women in that cohort had detectable PrEP in dry blood spots at 6 months. So the pregnancy periconception group is kind of clustering towards maybe slightly more likely to be able to take PrEP, which I think is important as we think about who might we want to prioritize for future work, especially with oral PrEP, given some challenges with cabotegravir in pregnancy, since we don't have that much data around pregnancy yet. And I'll turn it to Christina.
Thanks, Lynn. So we're going to shift our sets, our cognitive set a little bit to a different region of the world and talk a little bit about work that we are both doing in Alabama. And Lynn, I'm not sure if you advanced the slide, but if you could, that would be great. Okay, great. So just, I don't want to spend too much time, but just to kind of share a little bit about kind of the scope of the problem of HIV among women in the South, in particular Alabama. I have 2 slides here, and it looks like the reference isn't here, but these data, this slide and the next, come from AIDSview, and I just want to put a plug for AIDSview, which is an interactive online tool led by Dr. Sullivan to help us kind of contextualize the impact on HIV and different communities in different ways. And it can help us understand kind of incidence, prevalence, but also these things relative to use of tools that may help us prevent HIV, like PrEP. And this slide shows a PrEP to need ratio for the state of Alabama. So essentially this depicts the number of PrEP users. These data are from 2018 to the number of people who were newly diagnosed with HIV in a given time period. And a PNR or PrEP to need ratio on the lower end of the spectrum indicates a greater unmet need. So you can see if we look at men, their PNR is around 3.5 versus women, we're at 0.93. So highlighting, again, kind of this high need for HIV prevention among women in Alabama, but kind of a low uptake of PrEP so far. Next slide, please. And again, this is kind of showing actual PrEP numbers also from AIDSview in Alabama as of 2019. So if we look at the top bar here, shows that almost all PrEP users in Alabama identify as men. And it's broken down there a bit more by age in the second bar. But again, we see kind of a huge disparity for women, particularly African-American women. Next slide, please. So I'll talk a little bit about a study that I am co-leading with Dr. Miriam Kempf at UAB, and we refer to this study as the We Expand study. And this is an implementation science project funded by NIMH to help us understand how we might promote PrEP uptake among cisgender African-American women in Alabama. And I just want to have a moment to give credit to our study team members who are reflected here. Next slide, please. The objectives of the study are several. In the first aim, we conducted some qualitative interviews with clients and providers to kind of understand preferences, attitudes, perceptions of PrEP in the primary healthcare setting, and factors that might influence implementation. We used those data to adapt and develop a client-provider PrEP communication tool that's based heavily on available CDC provider PrEP communication tools that are widely available online. And then we are conducting an implementation science project to essentially implement this communication tool and understand if it's effective in helping women talk to their providers about PrEP and potentially uptake PrEP. And the long-term goal of this work, again, is to kind of better understand how we might integrate PrEP services into the primary care setting. And we're focusing exclusively on African-American women in Alabama for this project. Next slide, please. So I'll present the qualitative data today, which is parts of it were presented at IAS last year, and it's in preparation. And then I'll just give a brief overview of the implementation study, which is well in progress at this time. But we conducted individual in-depth qualitative interviews with three groups of individuals, really. Women who were not currently living with HIV. Some had PrEP experience, very small number, and most did not have PrEP experience. And then providers who serve these clients in rural Alabama at federally qualified health centers. Next slide, please. What did we ask? We asked clients about their general attitudes and preferences for seeking healthcare, particularly as it might relate to sexual health. We asked them how they think about how at risk they might be for HIV acquisition. We explored kind of how much women knew about PrEP and what they thought about it. For those women who had PrEP experience, we asked them to share with us their experience with PrEP, what went well, what didn't, and what they thought might help us implement PrEP into the FQHC setting. And unfortunately, this work kind of dovetailed with COVID. So we asked some questions about COVID as well. On the provider end, we asked about their experiences kind of having conversations about sexual wellness and health with women of color in Alabama. Again, similarly, their attitudes, perceptions, and understanding of PrEP, their experience with PrEP, and their experiences implementing or delivering PrEP. So I'll present now some of the kind of thematic findings. So as you might imagine, in order to openly discuss sexual health and wellness as a kind of a stepping stone to having a conversation about PrEP, effective provider relationships were really key to these successful conversations. Women needed to develop trust with their providers. In some cases, that could be achieved via longevity, but a lot of times there were behaviors that didn't take a lot of time to display, but were very important. So providing comprehensive information, appearing warm and empathic, and taking steps to communicate the importance of privacy. Clients wanted to feel like providers care about them. They ask about their personal lives, follow up on past concerns, and in some cases check in between appointments, particularly if a new treatment was started or if the client was meant to be thinking about a treatment decision. And also, as you might imagine, kind of what emerged here were behaviors that we might kind of label as shared decision-making between provider and client. So talking about the pros and cons of treatment or prevention options and talking about them specific for that individual client as well as more broadly, and giving clients time to process decisions. So very few of the clients felt that they would be ready to kind of start a new medication or prevention tool kind of in the moment. They wanted time to kind of review the information with friends and family, and also to think about it for themselves. And I think this has implications as we think about talking to people about PrEP in kind of short clinic visits. Next slide, please. Here are a couple of quotes kind of illustrating the effective provider relationships, or kind of the opposite of that. But the first client here reflects on how a provider made her feel comfortable and showed a lot of warmth. The second client here talks about a provider kind of checking in on them outside of a session, and that communicates kind of trust and caring that facilitates an effective relationship. Next slide, please. There are numerous barriers to effective client-provider relationships, many of which are reflected here, and I'll talk about some of them in greater detail. But in many cases, they're the converse of what I just mentioned. So a lack of empathy, long clinic wait times, a provider who was not perceived as warm. Some clients had general kind of clinic or health related anxiety that made it difficult to communicate with providers. Many of our clients had a history of negative provider interactions, at the same clinic, at different clinics, but that made it difficult to kind of engage in a meaningful way. Perceived judgment from providers, or a provider who didn't take kind of a whole body, whole picture view of a client's health and kind of zeroed in on one thing that may or may not have been the most important thing for the client. Next slide, please. Some quotes just to illustrate some of the key barriers. Again, kind of the first quote here is around a provider, a client feeling that they weren't being listened to, and again, having a kind of a disconnect between what the client wanted to talk about and what the provider wanted to talk about. The second quote, just a client talking about the attitudes and kind of how they were being rushed through the visit. And then lastly, this client talks about engaging in a procedure and being uncomfortable, and when they communicated that, the provider basically said, "Don't worry about it. We won't take much longer," rather than trying to work through the discomfort or stop the procedure with the client. Next slide. In terms of communication barriers around sexual health and HIV, probably not super surprising here, but a big one was clients' fear around being judged negatively by providers. Sometimes providers too just assumed that clients had sufficient knowledge and didn't really need information, or if the client didn't bring up sexual health or HIV, that they just didn't need that information. Limited time and competing demands is a pretty significant finding that emerged from the provider perspective, that providers are just being asked to do more and more things with less and less time, and sometimes there are things that are quite acute and need to be prioritized, and so then who is left to talk about sexual health and HIV prevention with the clients. And in some cases, providers did possess limited knowledge around HIV care and prevention, and in some cases it was biomedical HIV prevention in general, but also more nuanced questions around how does one pay for it, how does one access it, and that sometimes got in the way of even bringing it up to their clients. Next slide, please. The first quote here from a nurse practitioner, again, kind of if the provider is uncomfortable talking about sexual health, then that probably translates to the client and kind of creates an uncomfortable environment where these topics may not be raised. The second quote here talks about fear of judgment around sexuality and wanting to be very clear that this needs to be a safe space in which to talk about very personal and intimate information. And then lastly, I think this quote is interesting. So this is from a nurse practitioner as well, who kind of relies on the provision of data to kind of maybe close the gap between an individual client's sense of risk and kind of what our data show. Next slide, please. With respect to provider perspectives on PrEP, many of the providers that we interviewed, which again were providers who worked in an FQHC setting, felt that they didn't at the time of interview possess adequate training on PrEP, and felt more comfortable talking with clients about condoms and other prevention strategies. Some providers had opinions about who should best have these conversations about PrEP with clients, and kind of it depended on who you asked, but there was a real variety and kind of a spectrum of provider sense of where these conversations could be held. And then just a lot of questions, understandably, around the availability of PrEP and access in Alabama, particularly as it relates to payment and having clients who are under or uninsured and how they might pay for PrEP. Next slide, please. Some of these concepts are illustrated here in these quotes, but also kind of some of these quotes reflect, clients' misunderstanding or beliefs around PrEP. And again, kind of the understanding that if you use PrEP, you might actually be living with HIV rather than trying to prevent it. And again, another provider talking about feeling uncertain as to what the side effect profile might be for PrEP and needing to understand that before introducing it to a client. Next slide, please. With respect to client perspectives on PrEP, again, not surprisingly, and I think consistent with other qualitative data, clients prefer to access PrEP at places that kind of don't scream infectious disease. And clients felt this was important to kind of normalize PrEP use and decrease stigma. Navigators emerged as a very important tool to help people be the bridge between provider and client and help people kind of navigate the road towards access. And women in particular felt that PrEP was just not being marketed to them, and it certainly wasn't being marketed to women of color, and that we really needed to work on that to make it clear that PrEP was for women and also for women of color. Next slide. So again, this kind of understanding that this first quote that PrEP isn't for women, it's only for gay men, again, kind of wanting to see PrEP kind of out there in the world more normalized more, and having advertising campaigns that reflect people who may benefit from PrEP use. Next slide. Okay, so I'm mindful of time here, but just to quickly introduce the next phase. So all of our qualitative data kind of came together, and we developed this provider, patient, or client communication tool, the first page of which is reflected here. And we're currently testing this in an implementation science study, as I mentioned. Next slide. And this just kind of maps out our study flow and procedures and kind of what we're studying. And you'll see here that when we wrote the grant, we had our screening designed around high and low risk, and then kind of reviewing the literature and just trying to stay current in our qualitative data. We decided to take risk out of it to avoid further stigmatizing women and sending the message that sex is risky, and that in order to take PrEP, you are risky. And now we're really just kind of presenting it to all women who are sexually active. We're presenting the study to those women and taking risk out of it, normalizing it. This is a tool for sexual wellness. And women that are interested in our study will be recruited, consented. They will schedule a time to meet with their provider, go through our communication tool. And if they are not interested in PrEP, that's fine. We'll follow them, give them some questionnaires. And then the women that are interested in PrEP will be referred to a local PrEP clinic, and they will meet with our colleagues in the PrEP clinic, learn more, potentially uptake PrEP, or they'll decline. And we're following them either way for up to 3 months and collecting a lot of data to understand decisions and how they perceived our tool. Next slide.
Great. And I'm just going to briefly talk about two, one really studies that I've been leading with adolescent girls and young women in Alabama that have strikingly similar findings to what Christina just talked about. So this was a CFAR supplement with EHE supplemental funding to the UAB CFAR looking at PrEP use among adolescent girls and young women in Alabama. We did conducted provider and client interviews and some survey data as well. And this is our study team here. And I'm just going to show 2 slides on our findings. Samantha Hill, who's a recent early stage investigator and an adolescent health provider here at UAB, led this study looking at our provider findings. And I'll just say this really overlaps with what Christina just shared. Providers don't prescribe PrEP to adolescent girls and young women. Major theme is stigma relating to talking about sex and sexuality. And it's not, these are adolescent girls who mostly had male partners. It's sort of like majority sexuality stigma, not just minority group sexuality stigma. Like all of the sex is stigmatized, talking about it. Nobody wants to talk about it. So that's a major finding. Providers aren't comfortable with PrEP. Providers also see the same ads that the women see, and they also don't think that PrEP is for girls or young women. They think it's for gay and bisexual MSM populations, and so they don't think about it for girls and young women. And then there's a lot of healthcare systems and structural barriers that are very pronounced in Alabama that really impede PrEP access for youth. When we talked to adolescent girls and young women in this study, this analysis and paper was led by Madeline Pratt, who was an MPH student when she did this work. But the girls and the young women similarly talked about stigma around sexuality and sexual activity, as well as their race and gender in the clinic that made it hard to talk about sex, which led to them making, not really having a lot of discussions about sexual health. They were seeking information from lots of other sources like TikTok videos. But they've really learned a lot of this is a small sample size also impacted by COVID, but a lot of the girls and young women we spoke to had learned to advocate for themselves in healthcare settings. They came from a long line of women who had not felt welcome or heard or valued in healthcare settings. So they had learned to kind of ask for what they needed, but none of them knew that PrEP was an option for them. So they were asking about birth control, they were asking about STI testing, but they weren't asking about PrEP because they didn't know that was important for them. So as a follow-up to that work, we have Letitia Elopre and I are MPIs on an R34 to adapt content to train family medicine providers who see tons of people across rural America, train family medicine providers on understanding HIV epidemiology and that girls and young women are at risk here in Alabama, how to offer PrEP, how to prescribe PrEP, how to take a gender neutral sexual history, and also supporting PrEP champions. We actually have accepted that we're not going to get everyone on board, but if we can get PrEP champions in key clinics to help, we think that can make a big difference. So we're in the formative stages of that now and hope to have a piloted intervention in the next 2 years. And the other key helpers on that study are shown here. So conclusions from this piece of the work, the data that Christina and I both shared identify some key determinants of PrEP uptake among Black women in Alabama, which is a rural, ending the HIV epidemic focused state. PrEP for women and girls needs to be normalized in public facing contexts like marketing campaigns and integration into routine care. Providers in primary care settings like OBGYNs and primary care doctors and family medicine providers really do need some more support on taking a sexual history efficiently and prescribing PrEP and follow up to increase comfort talking with their clients. And they need training support around forming effective client-provider relationships. There's a lot of implicit bias and stigma around all sorts of things. And so figuring out, getting connections with providers that can generate relationship quality may be important in the type of provider. I think Christina was supposed to do that slide. So sorry if that was awkward. Christina, this is your slide.
You did a beautiful job with all of the slides, so please don't worry about it. But hopefully to kind of start off the discussion here for the last 11 minutes or so to conclude. So when we think about women, and again, as a priority population and people that may benefit from PrEP use, reach has actually been low, and we need to do better. Lynn's data, I think, show that PrEP uptake and use is high during the periconception period. And it's a very exciting time to think about PrEP in terms of different formulations and kind of getting rid of this daily pill burden. And those non-oral formulations may or may not address other lingering issues like provider knowledge about biomedical HIV prevention, attitudes towards their clients using it, towards sexuality in general, stigma associated with using biomedical HIV prevention, limited knowledge in the community around the availability of these products and the safety of them, particularly as we think about planning pregnancy and breastfeeding as issues that are particularly salient to women. All of the structural barriers that get in the way of having a successful conversation about PrEP in the healthcare setting. Understandably, people want and deserve information, and how do we support providers who don't have enough time? So thinking out of the box in terms of who can, again, serve as a bridge in between provider and client. Also, we need to understand what adherence support is needed and for whom. Not everybody will need intensive adherence counseling, but some people might. So who and when and where we provide that. And then lastly, again, I think kind of concerns about people who may be planning for or with pregnancy, and kind of the safety data for some of the other products is still emerging. So I think as a goal, thinking more towards away from kind of the traditional research designs and moving towards more implementation science models and hybrid designs to answer these questions and answer them quickly. Next slide.
And we just thank our funders, our participants, and the many people who contributed to the work. I'm also giving a shout out to Dr. Bosco Buona, who was the PI and a mentor to me for many years in Uganda, who died in early 2020 and was an amazing investigator and clinician in person. And I think we can take questions. And I'll stop sharing.
Thank you so much for such a well thought out and comprehensive framework to think and talk about these issues, and for the work that you've done. I'm just going to first remind our audience that you can pop questions into the chat, either to me or to the whole group, and I will organize them. But I'd like to start out by following up with one question for each of you about your presentation. So, Christina, I really was struck by the change that you sort of made in the sort of protocol around sort of taking risk out and normalizing the offering of PrEP. And so I just wonder, do you think is it premature, or is it time to think about changes in the PrEP guidelines about who clinicians should talk to about PrEP, and could that help overcome some of these barriers?
Yeah, thank you for that question. I think it is, I mean, I feel like this might be a loaded question, but I feel like, yes, it probably is. I appreciate the complexities that are involved in coming up with guidelines. So I just want to say that before I offend somebody. But I do think it is time. I think we are very clear that people sometimes have a hard time thinking about risk for so many reasons. No one wants to be viewed as at risk. Also, if you view yourself as being in a monogamous relationship, you're not at risk, and that may or may not be true. And so for so many reasons, I do. And also, I think we need to be particularly aware of further stigmatizing communities that have been stigmatized forever, and just adding this additional level of stigma around their sexuality to them. And so, you know, for that reason, I think among many others, I do think it's, why can't we normalize PrEP use and say this is a tool that you can use for sexual wellness? You know, here's the information that I might consider when making a choice. And if you tell me you want it and need it, I believe you. End of story. Let me help you get it.
Great, thank you. And then I wanted to go back to the first part of your presentation where you're talking about, you know, some of the data about oral PrEP for women who are either planning for pregnancy or who are pregnant. And I wonder if you could say a little bit more about alternatives. So I think the data point out some of the challenges and opportunities maybe of oral PrEP, but what about alternatives to oral PrEP for women who are planning for pregnancy?
Yeah, so I think that for anybody who has experienced being pregnant or postpartum, or is familiar with data from people who are pregnant and postpartum, it's a pretty difficult time to adhere to daily oral pills. So I think future data on how to offer long-acting options to women or people in that context is going to be really important. Right now, we have very limited data on cabotegravir safety data, structurally quite similar to dolutegravir. So structurally, there are a lot of overlaps that are reassuring. However, pharmacokinetic wise, it's like a whole different ballgame. So if women are exposed to cabotegravir during a pregnancy, there's a lot of exposure. And so I think that the CDC guidelines currently say that because the data for cabotegravir are so compelling, that if a woman wants cabotegravir in pregnancy, shared decision making, and they don't say it's contraindicated, but we do have very little data. And I think that kind of given where providers are, I mean, that's one thing to write that in guidelines, but given where providers are with the knowledge and where providers are currently with even TDF FTC in pregnancy, I think it's going to be a stretch for people to offer a lot of that. So I think it's going to be important to have more choices for different ways to get PrEP into people who are at risk during pregnancy and postpartum.
Thank you. I'm also really just grateful for you raising the issue of sort of PrEP equity, especially for Black women in the South. And like we, as your neighbors, as your Southern neighbors, also really see that this plays out across the South, particularly the inequity among women. And within women among Black women. So could I just ask both of you to say a bit about like where are we with interventions to promote PrEP for Black women? I mean, you talked about some of the principles, but how does that turn into interventions that are, provided and scaled up? Lynn, you're unmuted. You want to start?
Sure. I mean, I think that the NIMH, probably other agencies were involved, did have an RFA last year specifically for intervention, for studies to look at improving HIV prevention for cisgender women in the South. And part of the reason they did that is because the people at NIMH and NIH saw that again and again and again, those studies were not doing well in review and were not getting funded. And so they actually wanted some of those studies to get funded. So there's a kind of cluster of cohorts funded under that mechanism that are working on lots of different ways to try to improve PrEP access through interventions with providers and with women and with social marketing and all sorts of very creative and exciting ways to get more PrEP into the hands of cisgender women in the South with a focus on Black women. So I think that's one strategy that's very, kind of increasing the funding is one way to help do it.
Christina, do you want to add to that?
No, I actually think you covered that succinctly and nicely, Lynn. Increasing the funding is a good way. And also funding to a more diverse pool of persons too, right? I think is also important.
Yeah, I mean, I think that's one of those sort of, we can think of that as a structural kind of need that is not about the structure of healthcare settings, but about the inclusivity of researchers. And so I think I appreciate you raising that.
And community partners who do so much of the work. Yeah.
Yes. Well, unfortunately, we're coming down on time. I want to thank both of you again for such an amazing start to our sort of fall, kickoff to this series. and for the work that you've done, for the thought that you put into the presentation, and for how much I think this is going to provoke people's thinking. So thank you for that and getting us off to such a great start this season. I also want to let people know that our next session is going to be December 5th at 1 p.m. And that's going to be with Susan Little from UC San Diego, who's going to talk about the work that they've been doing for a long time on identification of acute HIV and the impact on transmission dynamics. So please join us for that. Thanks to all who've attended. And Ken, do you have any last words of wisdom?
No, again, thank you for such an excellent presentation, Lynn and Christina, and thank you everybody for your participation. And
Thanks
see
for
you
having
soon.
us.
Thanks for having us.
Thank you.
Take care.
Bye
Have
now.
a good afternoon. Bye-bye.
Well done. Thank you.
Thank you.